DCR surgery joins the lacrimal sac directly to the endonasal space, thereby bypassing the nasolacrimal duct. External DCR accesses the lacrimal sac and nasal mucosa from the skin surface, while endo-DCR performs exactly the same procedure, but with access from the endonasal space. This patient is under general anesthetic and has had local anesthetic with adrenaline infiltration and preparation of the nasal cavity with cofenolcane spray and ribbon gauze with cocaine 5% paste. External DCR can also be performed under local anesthetic, generally with some degree of sedation. Various different skin incisions have been described and will all generally heal with little or no scar if the incision is closed carefully at the end of the procedure. The incision can be straight or gently curvilinear. It is usually located approximately 3 to 4 millimeters from the medial canthus and extends from a few millimeters above the canthus to about 1 centimeter below and is about 1 to 2 centimeters long. With experience, the incision is likely to get smaller, although good exposure is always fundamental. Orbicularis is separated with blunt dissection. The angular vein is often seen and should be preserved if possible. The medial canthal ligament is an important landmark and is therefore useful to identify. It is disinserted to improve access to the lacrimal sac. It can also be transected, but disinsertion is probably preferable, as firstly, this will automatically create a useful opening in the periosteum, and secondly, may heal better postoperatively. The periosteum is opened along the full length of the incision just anterior to the anterior lacrimal crest. This can be commenced at the defect created by disinsertion of the medial canthal tendon. The periosteum is raised from the underlying bone with a small periosteal elevator, such as a Rollett's regine, both anteriorly and posteriorly. Anteriorly, a few millimeters should suffice to provide good exposure and ensure the periosteum will not be trapped in the rongeur during formation of the bony osteum. Posteriorly, the periosteum separates easily from the lacrimal fossa and lifts the lacrimal sac out of the fossa with it, but care is taken not to penetrate the lacrimal sac, as the end of the elevator is quite sharp. Traction sutures are very helpful, although not essential. 2 silk 4-row sutures on each side of the incision, spaced at thirds along each edge, will maximize exposure. A trachea periosteal elevator is slid posteriorly along the tough, thick maxillary bone until the soft bone is felt. This will give way either at the suture line between the maxillary bone and the thin lacrimal bone, or slightly more posteriorly at the anterior lamina papyracea. The heel of the elevator can be pushed gently inwards to create a defect. At this stage, it is essential to already be considering the location and delicate nature of the nasal mucosa, which is immediately under the lacrimal bone. The nasal mucosa should be kept intact, and to facilitate this, the periosteal elevator is carefully slid between bone and mucosa and rotated rather like a key in a lock to dissect between bone and mucosa. This should push the nasal mucosa away and create space between it and the bone. The small rongeur is carefully passed into the small lacrimal bone defect. The rongeur is again rotated to ensure that nasal mucosa is pushed well away and will not be caught in the punch. Several bony punches are made until the osteum is large enough to accommodate the larger rongeur. The punch must always be used to punch out sections of bone and not twisted to break off fragments, as this risks a spiral fracture extending superiorly towards the skull base. The lacrimal bone, including the posterior lacrimal crest, some of the frontal process of the maxillary bone, including the anterior lacrimal crest, and the anteriormost lamina papyracea will all be removed. The precise dimensions and location of the osteum are difficult to specify and vary from patient to patient and surgeon to surgeon, but some general guidelines are: 1. The entire lacrimal sac must be exposed with space for the lacrimal sac and nasal mucosa flaps to be opened fully. 2. The osteum is approximately circular or oval, with approximately a 15 mm diameter vertically and 15 to 18 mm diameter horizontally, or at least the size of a thumbnail. 3. Anteriorly, one can enlarge the osteum until the punch cannot be inserted between the bone and nasal mucosa. 4. Posteriorly, one can enlarge to visualize the anteriormost ethmoid air cell, which is the Agonese cell. 5. Superiorly, one can extend to 2 mm above the medial canthal ligament. And 6. Inferiorly, the superior nasolacrimal duct should be exposed. The The small risk of CSF leak must be considered. If the surgeon is unaware of the surgical landmarks and the location of the osteum, this could occur directly from extending the osteum too far superiorly and reaching the skull base at the roof of the ethmoid air cells or fovea ethmoidalis. However, it is probably more likely to result indirectly from twisting on a maxillary bone with the rongeur and causing a spiral fracture that extends superiorly and posteriorly to either the fovea ethmoidalis or the cribriform plate more medially. The risk is higher in cases with anomalous bone anatomy, such as those cases that have had prior trauma or congenital malformations, and preoperative CT scanning is mandatory in such cases. The agonese, or anterior-most ethmoid air cell, frequently overlies the posterior aspect of the lacrimal sac. This can be difficult anatomy to perceive and is much more easily visualized during endonasal DCR when the lacrimal sac is exposed and the agonese almost invariably identified and exposed posteromedially to the lacrimal sac. The inferior aspect of the lacrimal sac can be fully opened if some of the maxillary bone overlying the superior aspect of the nasolacrimal duct is also removed. A nibbler is a useful tool for this and is carefully slid over the bone with nasolacrimal duct anterior to one prong and nasal mucosa posterior to the other prong, as always, ensuring that the nasal mucosa is not trapped. The puncti are gently dilated to accommodate a Bowman probe. Aggressive dilatation should be avoided, as this probably disrupts the punctal sphincter, which could conceivably have an impact on tear drainage. A Bowman probe is passed along either the inferior or superior canaliculus and into the intact lacrimal sac. It is used to tent up the sac. The glint of metal should be seen through the translucent sac. If it is not seen, the probe is probably not fully in the sac. Most likely that a fold has been created in the canaliculus, and probing should be tried again with a slightly different trajectory. Alternatively, canalicular pathology exists, although this should have been identified during the preoperative examination and imaging. True canalicular membranes do exist, but are exceedingly rare. An alternative technique is to dilate the lacrimal sac with viscoelastic or chloramphenicol ointment. When learning DCR surgery, this enlargement of the sac can make lacrimal sac incision and flap formation easier. With the lacrimal sac still tented up by the probe, a horizontal incision can be made in the superior-most aspect of the sac. A cataract surgery keratome is a very useful instrument for this, although a regular number 11 blade can also be used. Westcott's spring scissors are used to make the longitudinal incision down the length of the lacrimal sac, ensuring that adequate anterior and posterior flaps will be formed. Finally, a further horizontal incision is made at the inferior-most aspect of the sac. The probe should now be easily advanced and visualized. In this operation, nasolacrimal stents are not being used. They do not increase the likelihood of success in cases of nasolacrimal duct obstruction. We do use them in cases of canalicular disease or if the canaliculus feels tight or abnormal during intraoperative probing. Currently, it is unknown if stenting improves the success rate in cases of functional delay or obstruction. This excerpt from another external DCR procedure shows the placement of O'Donoghue tubes. The O'Donoghue tube stillets have been bent into a gentle curve and are passed through the lower and upper canaliculus in turn. They are then clipped to the drape to retract the anterior lacrimal flap and medial incision edge. A cotton bud or blunt instrument, such as the Stallard being used here, is passed into the nasal cavity and used to palpate and tent up the intact nasal mucosa. Again, a keratome and spring scissors are used to create anterior and posterior nasal mucosa flaps with a central longitudinal incision and a horizontal incision at the top and bottom, rather like a capital letter I. With experience, one can estimate how big a posterior flap will be required to approximate with the posterior lacrimal sac flap and make the longitudinal incision accordingly. The posterior lacrimal sac and nasal mucosa flaps are laid down and their size checked. Occasionally, the posterior nasal mucosa will need to be trimmed to allow them to oppose neatly. A 6-0 vicryl suture is pre-placed in the anterior lacrimal sac flap. This suture is useful for both retracting the flap during suturing of the posterior flaps and for quickly identifying the lacrimal sac flap later. The posterior flaps are sutured. In this case, 3 sutures are being placed using a vicryl 6-0. The half-circle needle makes this stage much easier. Conflicting outcomes have been reported in studies of external DCR with and without posterior flap closure, although none have been adequately performed or powered to definitively answer this question. Intuitively, it seems prudent to oppose mucosa to mucosa in the hope of reducing fibrosis over the osteum, and therefore we suture both posterior and anterior flaps. A further 3 sutures are placed to join the anterior lacrimal sac flap to the anterior nasal mucosa flap. Surgeons vary in how they close the DCR incision. This video demonstrates reattachment of the medial canthal tendon and closure of orbicularis, followed by a continuous suture to close the skin. Some surgeons, however, just close the skin.